Welcome to our 8th lesson in our 12-lesson series. This lesson deals with advanced Parkinson's disease. It is divided into 2 parts. The first part introduces the challenges of recognizing the late-stage Parkinson's disease, and enabling the access to palliative care services. Part 2 is dealing with organizational and communication issues in late-stage Parkinson's disease, which help to reduce suffering and maintain patients and their families' quality of life at the final stage of the disease. First, we will speak about how to recognize the final end-of-life phase of Parkinson's disease. You will get to know what alterations in the care plan and management are advisable in this phase of the illness trajectory. Then you will get some notions when palliative and end-of-life care measures are to be intensified. Most important aspects at this stage are the communication and advance planning discussions. Especially important are decisions on possible withdrawal or withholding of the treatment. Finally, we look at the topic of equity in accessing palliative care services. How to recognize the final phase of Parkinson's disease. Over the past decade, the perspective on Parkinson's disease has changed significantly. The classical view emphasized the leading symptoms, which consist of akinesia, rigor, and tremor. The new perspective has a greater awareness for symptoms, which are not as obvious, and therefore, more difficult to detect and manage. Among these symptoms are sleeping difficulties, mood changes, swallowing problems, attention loss, and memory problems, issues with sexuality, but also pain, fainting, and weight loss. How to provide relief related to these symptoms will be discussed in Lesson 10. In this lesson, we try to establish the final phase of Parkinson's disease. In 2016, 6.1 million people globally were diagnosed with Parkinson's disease. That is 2.4 times more than the number of people diagnosed in 1990. According to experts, this amount will increase even more in the foreseeable future. The main reasons for such a significant rise are certainly better diagnostics, but also the demographic change of having a large number of older people impacts the numbers. Dexter and Jenner have stated that approximately 3% of the population aged 65 or more years become diagnosed with Parkinson's disease. In the age group 85 plus, up to 5% are affected. In 2017, Enders and colleagues claimed that 15 to 20% of the whole population with Parkinson's disease are in an advanced or late stage of their disease. This picture illustrates the difficulties when having to prognose the disease trajectory in patients with Parkinson's disease. Due to the unpredictability of the disease trajectory, it is, even for professionals with many years of expertise in the field, a demanding task to prognosticate the course of this disease. In earlier lessons, we have established that the disease trajectories in patients with Parkinson's disease are often difficult to predict and define. Typically at the beginning of the treatment, or at point 1 as shown in the figure, improvement in mobility and other symptoms are reported. At point 2 the treatment might not work as well as in the early phases of the disease. Dementia and hallucinations might occur. When the patient reaches point 3 the treatment options are limited and often ineffective. From this point onwards, a continuous decline will follow. Several international studies have stated that predicting when a patient has reached the advanced stage is challenging. Criteria that affect Parkinson's disease are decreasing effectiveness of medication or increasing complexity of the regime, decreased independence, increasing uncontrolled phases with increasing off phases, phases with dyskinesia, mobility problems, falls, psychiatric signs such as depression, anxiety, hallucinations, psychosis, and increased frailty. Yet, there is until now, no clear cutoff point. For example, something that could be detected by simple test, or easily determined by checking the blood values. Therefore, different indicators have to be considered to define if the patient has reached an advanced stage. Nearly all authors suggest using the Cohen and Yahr scale, which was published in 1967. The Hoehn and Yahr scale measures the illness progress, and is used to access the level of disability. At stage 0 there are no signs of disease. At further stages, symptoms manifest on one side only, becoming unilateral and involving the neck and spine. At stage 2 we see symptoms on both sides, but no impairment of balance. Further mild symptoms manifest on both sides, but when the pull test is given patient recovers. In the pull test, the healthcare professional stands behind the person and asks them to maintain their balance when pulled backward. Balance impairment, mild to moderate disease, physical independence are the signs of stage 3. At stage 4 we see severe disability, but the patient is still able to walk or stand unassisted. Finally, at stage 5, patient needs a wheelchair, or is bedridden unless assisted. Having reached Hoehn and Yahr stages 4 or 5 typically indicate the advanced stage of the disease. Such an advanced phase influences nearly all aspects of day-to-day lives of patients and family carers, which also comes with higher caregiver burden rates, anxiety, depression, economical burden, and generally an overall lower quality of life. In general, there are some triggers for chronic neurological diseases, whose occurrence allows the identification of the last phase of life. These triggers are dysphagia, repeated infections, especially aspiration pneumonia, significant decrease in functional congestion, first episode of aspiration pneumonia, cognitive difficulties, weight loss and significant complex symptoms, and the overall impression of the professional team. In the case of Parkinson's disease, additional triggers have been identified. These are rigidity, pain, agitation and/or confusion, due to sepsis and neuropsychiatric deterioration. The number of triggers increases as death approaches, and aspiration pneumonia has been seen in the last 6 months of life. The McMahon model divides the course of Parkinson's disease into 4 phases. During the diagnosis phase, medication is started and rehabilitation measures are applied. On average, this phase of the disease takes 1.6 years. The maintenance phase consists of the time in which function and self-care can be maintained. Normal activity can continue. Multidisciplinary care of the patients is sometimes required. The average duration is 5.9 years. The complex phase is a phase of increasing limitation and complexity. Symptom control is a topic of this phase. Drug management becomes more complex. The complications increase. Swallowing difficulties and aspiration may occur. The average duration is 4.9 years. Finally, the disease enters a palliative phase. The drugs become less effective, other comorbidities occur, and symptom management and the preservation of dignity are the focus of care. The reduction of medication should be considered, complications prevented and treated. This stage lasts on average 2.2 years. The McMahon model highlights the progressive and incurable nature of the disease, and the need for optimal symptom control and psychosocial support, to maintain quality of life throughout all stages. And finally, the so-called surprise question, can also be used, to estimate the advanced stage of illness. When looking at your patient, ask yourself, would you be surprised if the patient died within the next year? Within a month? Within next weeks or days? If the answer to this question is no, this indicates that the patient is at the advanced stage. When the final decline has been determined, it is time to begin with the end-of-life care. We have already established that ideally, all patients should have access to basic or generalist palliative care. Depending on the necessity and needs, this care can be useful at any time during the illness trajectory. Often, generalist palliative care provided by family doctors or primary care professionals, such as community nurses, with additional training in palliative care is sufficient. At the advanced stage, however, patients and families face more complex problems, which may require specialized palliative care services. At the final stage of the disease, the focus should be on reducing suffering and maintaining the quality of life. Interestingly, many studies have demonstrated that patients with access to palliative care services report less illness-related suffering, and live longer than those without. In 2009, a German study conducted by Snell and colleagues demonstrated that only 9% of patients with Parkinson's disease die at home. According to this study, 91% of Parkinson's patients died in the hospital or in a long-term care facility. Another German study compared the admissions of neurological and oncological patients to palliative care units between the years 2007 and 2011. All in all, 1,472 patients were included. Of 86 Parkinson's patients admitted to PCU, 12% died, few were transferred within the hospital or to a nursing home. In the majority of admitted Parkinson's patients, the changes in medication but also educating the relatives, supported leaving the PCU to be cared for at home. Whereas, of cancer patients, almost 60% died in PCU. In recent years the German government has made several investments to improve access to palliative care services. One of the main foci has been improving outpatient services, and in-home end-of-life care. One of the main pillars of the German healthcare system is the desire to have an efficient and functional outpatient care service for people with life-limiting diseases. To make this happen, coordination and collaboration between nurses, social workers, general practitioners, palliative care specialists, and allied professionals are of major importance. Non-elective ICU admissions at the end of life, which occur mainly due to unmet health or social care needs, cause distress in patients and relatives, are one of the main causes for moral injury in healthcare professionals, and thus, come with high socio-economical costs. For patients with Parkinson's, hospice admissions come with several barriers. For example, in some countries, patients with feeding tubes might not be eligible for hospice. However, in terms of hospice admissions, Goy and colleagues have published some predictors regarding Parkinson's disease. In our experience, these predictors are not fulfilling all possible criteria, and some patients are doing quite well with only 2 medications. Therefore, we have slightly amended this list of possible predictors for hospice admission. Hospice or specialist palliative care referral is needed if the patient's body mass index is below 18, or if the patient takes 2 or fewer dopaminergic drugs, suffers from severe dementia, or terminal delirium, is bedridden, or has dysphagia or anarthria. Consultation with family is of the essence in decision-making. We shall discuss the symptoms and symptom management in Lesson 9 in detail. Here we wish to point out the importance of including families in decision-making. At late stage, some Parkinson's patients suffer from depression and anxiety, which are difficult to detect because of severe communication problems. Families' perceptions can be of help to determine and address psychological and spiritual distress. Also, socio-economical determinants may affect the complex symptom management characteristic to palliative care. When discussing admission to palliative care, it is important to know that admission to specialist palliative care may significantly prolong and improve patients' illness-related suffering. The following case study introduces a patient who was diagnosed with Parkinson's disease in 1997. In 2009 he faced many complications. After rehabilitation, a stay at the psychiatric hospital, and an ICU visit, he was admitted to the palliative care unit. After his stay at the palliative care unit, he was able to leave for home, walking. This patient lived for 3 more years. Finally, we would like to mention few important medical decisions that need to be made in Parkinson's disease. Lorenzel and colleagues have introduced a 5-step model for decision-making. In the beginning, a frank discussion of treatment options and restrictions with the patient and all family members and surrogate decision-makers is desirable. This discussion is called a family conference. Secondly, defining the therapeutic goal. Defining the actual resources of the patient to rely on, and to choose from options of life-prolonging treatments, and to restrain treatment. At step 3, decisions must be validated, whether they are consistent with the patient's desire, which might be documented in an advance directive. Fourthly, the physician should provide a decision and suggestions, based upon ethical and moral principles, and the results of steps 1 to 3. Finally, the treatment or symptom management can follow the results of this concerted action. The decision-making process in Parkinson's disease has to be a synthesis of the patient's physical, emotional, socio-cultural, socio-economical, and spiritual situation. Things to be cautious of are the safety of care and possible paternalism, either in healthcare facilities or within the families. Connecting all these factors may result either in jointly supported autonomy or inborn autonomy. The care management in palliative care is successful when jointly supported by all involved in caregiving. Regarding the late stage of Parkinson's disease, the following recommendations should be considered to provide the best care for patients and relatives. Respecting disease trajectories in the late phase and accepting the decline. Carefully considering the benefits of antibiotic treatment, or feeding tube placement. Checking for all possible treatment options, including apomorphine and duodopa treatment, which is seen as more invasive treatment. Thinking of how to provide care and support for the relatives. Respite care provides short-term relief for primary caregivers, and can be arranged for just an afternoon, or for several days or weeks. Respite care can be provided at home, in a healthcare facility, or at an adult day center. Also remembering that sometimes, no matter what, suffering cannot be managed or reduced. Particularly then, all that is required from healthcare professionals is being there and being present. Communicating to patients and families that together we will endure the situation, is a strong and important message. When discussing access to palliative care, we cannot ignore the issue of inequity. There are a number of different factors that influence access to palliative care. These include gender, ethnicity, cultural, religious, migration history, sexual orientation, as well as economic status. Therefore, the next slides will deal with aspects of diversity. But first of all, there are some factors that make it difficult to describe the barriers to accessing palliative care for minorities in a general sense. On the one hand, it is difficult to speak in general terms for the contexts in different countries. Secondly, here are few studies examining the intersections of Parkinson's disease and other diversity categories. But it should be noted that people belonging to several groups that may be specifically affected by disadvantage. And finally, the categories mentioned above also intersect with the general misinterpretation of palliative care and hospice services. Ethnicity is a multifaceted and changing phenomenon that may reflect a combination of a number of features, including country of birth, nationality, language spoken at home, ancestral country of birth, skin color, national or geographical origin, ethnical group and religion. Access to palliative care for patients belonging to ethnical minorities can be a particular challenge for all involved, both for the patients and for the health professionals. Recent studies indicate that patients from ethnic minorities are less likely to have access to palliative care. As a result, their palliative care needs remain unmet. One difficulty can be the language barrier, which makes it difficult to provide adequate care. When these are available, healthcare professionals rely on translators and mediators. Otherwise, relatives of the patient often also act as intermediaries. Palliative care for people with a migration history often takes place without specific knowledge of the migration biography. As a result, this leads to lack of opportunities for communication, end-of-life decision-making, and health outcomes, for example pain. In addition to the appropriate involvement of family members, autonomy and independence, religion is an important aspect of maintaining dignity in the last phase of life. There is evidence that there is low uptake of end-of-life care by people from cultural, ethnic minority groups. Requirements for religious or cultural care at the end of life, that do not meet the needs of the majority society, are rarely implemented at present. The influence of sex and gender on the occurrence, course and care of diseases, has become increasingly important in many areas of medicine. This is also indicated by the increased number of publications in recent years. Sex refers to the biological factors. Gender refers to socio-cultural and behavioral factors. Both aspects have a great influence on care. While sex can modulate disease progression and response to therapy, gender can influence patient-physician communication, non-pharmacological disease management, and the need for support. The category of gender also has an impact on the care of people with Parkinson's disease. The numbers vary greatly depending on the country. However, in European countries, men are thought to be affected 1.5 to 2 times as often as women. Women with Parkinson's disease are more likely to have tremor-dominant disease, a later onset, and a slower rate of progression. They are more likely to be affected by visuospatial disturbances, and respond to dopaminergic stimulation with dyskinesia. They also have higher levels of anxiety. Compared to men, they tend to have less social support, and fewer informal care resources. In addition, women are underrepresented in Parkinson's clinical trials. Saunders Pullman and colleagues reported in their study that there is a significant delay in referring women with Parkinson's disease to movement disorder specialists. By contrast, men were more often affected by increased daytime sleepiness, a more pronounced sialorrhea. They also had more frequent REM sleep disturbances and more reduced verbal fluency. In general, however, such comparisons should be viewed with caution. Even clinical studies are not free of gender bias and gender-specific attributions. Gender has an impact, not only on patients, but also on family caregivers. The majority of care work is done by women worldwide. Men at the end of life are more likely to be cared for at home by their longer-living wives. In contrast, women who are widowed are statistically more likely to be dependent on care services, and often in a worse economic position than men. As more men than women are affected by Parkinson's, there are more female caregivers. Female caregivers reported exhaustion, social constraints more frequently, and time constraints more often than men, and they are more likely to report negative consequences of the progression of the disease, such as excessive demands and lack of freedom. Morley and colleagues describe in their study fewer negative outcomes, and less impaired quality of life in male caregivers. Less is currently known about LGBTQIA+ and Parkinson's disease. However, there are online reports from those affected. Some of the aspects mentioned here will be mentioned in the following. They are more likely to live alone, less likely to have children to support them. And they may be estranged from the rest of their family. Perhaps there is a sense of shame in talking to healthcare professionals about these aspects of life. Social support depends strongly on the social circumstances. This includes whether a person lives in a larger city or in the rural area. In cities are usually more connections for the LGBTQ community, and also more support groups for people with Parkinson's disease. There may be a concern about not being accepted in Parkinson's disease support groups or other institutions. However, there is a lack of research in this area, and personal circumstances can be very different, and lead to very different experiences. Socioeconomic status also systematically influences the risk of disease and mortality, for example, the time of death. Thus, people with a higher socioeconomic status, measured by educational level, occupational status, and net equivalent income, live significantly longer than comparison groups with a lower status. there is also a higher rate of comorbidities. The question arises, whether this correlation also applies to the how of dying, and end-of-life care. How someone dies, depends not only on the type of insurance and the socio-economic status, but above all, on the place of residence, for example on the infrastructure available or lacking depending on the region. This is especially applicable to the treatment of chronic and multifaceted diseases, such as Parkinson's disease. The question arises, as to what recommendations there are for practice. In general, more information about palliative care services needs to be disseminated. The goal is a uniform access to the use and quality of palliative care services. Diversity in the organization of services can be very valuable in many ways. Furthermore, heterogeneous groups and identities should be valued. Religious and cultural needs should be respected. This includes recognizing that not all people share the same values. It is also important to raise awareness that categories of diversity affect all people and not only minorities. Avoiding stereotypes, and treating each patient as an individual, rather than as a member of a particular group. It can be assumed that in particular training on the diversity aspects mentioned on cultural, religious and gender competence, and effective communication and translation services, can be of great benefit in making adequate care accessible to more people. Research at these intersections will be necessary in the future.